New insights into migraine pathophysiology. Since data has shown that an extensive number of headache patients describe their pain symptoms as originating near and/or in their sinuses, it is typically assumed that the pain experienced is caused by the sinuses themselves. However, a closer look at the pathophysiology of migraine may lead to a different conclusion. To better understand the relationship between sinus symptoms and migraine, it is critical to review the latest understanding in migraine pathophysiology. Migraine research has found that the trigeminal nerve, the trigeminal nucleus caudalis located in the brainstem, the brain, and the vasculature within the meninges of the brain play fundamental roles in the progression of migraine. The ophthalmic, maxillary, and mandibular branches of the trigeminal nerve function as the sensory nerves for the face, sinuses, and meninges. One of the current migraine theories focuses on the connections of the trigeminal nerve and its associated vasculature within the brain's meninges. This theory explains that a migraine begins when certain triggers provoke a diffuse neural dysfunction within the brain and brainstem. The diffuse neural dysfunction causes a cascade of events, including vasodilation of meningeal blood vessels and activation of the trigeminal system. The dilated blood vessels cause stimulation of the trigeminal nerve terminals on the blood vessels, resulting in the release of vasoactive neuropeptides. These neuropeptides induce neurogenic inflammation, exacerbate vasodilation, and have been linked to the pain of migraine. Interestingly, triptans, routinely prescribed for migraine headache, are believed to relieve migraine pain by interfering with the vasodilation cascade. The triptans bind to 5-HT1B receptors on the meningeal blood vessels, which decreases vasodilation. Triptans also bind to 5-HT1D receptors on trigeminal nerve endings around blood vessels, which blocks the release of the neuropeptides, thereby reducing vasodilation and inflammation. Without triptans, the inflammation and vasodilation may result in pain impulses that are transmitted via the first and second ophthalmic and maxillary divisions of the trigeminal nerve. Pain impulses are then carried to the trigeminal nucleus caudalis, TNC, located in the brainstem. Pain signals reaching the TNC during migraine are relayed to higher-order neurons in the thalamus and cortex, resulting in referred pain. Referred pain may also be perceived in the head, neck, and face. In a sinus-like presentation of migraine, pain may be referred to the ophthalmic and maxillary regions. This sensation of pain may result in patients complaining of pain or pressure around the eyes and sinuses during a migraine attack. The involvement of the parasympathetic nervous system during migraine may help explain other sinus symptoms. The parasympathetic nervous system includes the superior salivatory nucleus and nerve fibers that travel with the maxillary division of the trigeminal nerve, extending to the sinuses and tear ducts. Some of the sinus symptoms of migraine are due to stimulation of the parasympathetic nervous system. The superior salivatory nucleus, part of the cranial parasympathetic nervous system, lies in close proximity to the TNC. Activation of the TNC during migraine may result in reflex activation of the superior salivatory nucleus. Parasympathetic fibers exiting the superior salivatory nucleus run parallel to the trigeminal nerve branches and innervate the sinus cavities and tear ducts. The reflex activation of these fibers by the superior salivatory nucleus during migraine results in sinus symptoms such as rhinorrhea, nasal congestion, and lacrimation. These symptoms, in combination with the perception of sinus pain or pressure, may mislead physicians to a diagnosis of sinus headache instead of migraine. Thus, we can conclude that the pathophysiology of migraine, with involvement of the trigeminal nerve, is consistent with the clinical data and observations that sinus symptoms often accompany migraine attacks. Activation of the TNC can result in sinus symptoms including perceived pain in the sinus area innervated by the trigeminal nerve fibers and reflex activation of the cranial parasympathetic nerves producing lacrimation, rhinorrhea, and nasal congestion. As a result, In patients with recurrent disabling headache accompanied by sinus symptoms and the absence of infection, the diagnosis of migraine would seem appropriate. The ongoing research in migraine is assisting physicians by increasing the awareness, knowledge, and diagnosis of migraine, with healthcare providers renewing their commitment to recognize and manage the disease through careful, diligent, and appropriate patient diagnosis. Successful treatment of the 14 million undiagnosed migraine sufferers can occur.